to our members. The session is being recorded and will be uploaded to the RACGP Victoria Resources page, and the video link will be sent to you along with the survey. If you have any questions, type them in the box, and at the end of the presentation, we will have a specific question answer sessions to answer as many questions as possible. Now, I have the pleasure of introducing our presenters. Our first presenter is Associate Professor Victoria Ma. Professor Ma is a fellow of the Australasian College of Dermatologists and director of the Victoria Melanoma Service. She is adjunct associate professor at the School of Public Health and Preventive Medicine, Monash University. She completed her PhD at Monash University VMS at the Peter MacCallum entitled Clinical and Molecular Characteristics of Aggressive Melanoma in 2014. She is a board member of the Skin and Cancer Foundation Incorporated and the Melanoma and Skin Cancer Trials group, through which she is involved in a number of investigator-led clinical trials. She has authored and co-authored a number of chapters for the Cancer Council Australia's Melanoma Guidelines and is clinical lead for the Melanoma Clinical Outcomes Registry. Our second presenter is Associate Professor Shahneen Sandhu. Professor Shahneen Sandhu is a medical oncologist and an early career researcher with a full-time appointment in skin and melanoma units at the Peter MacCallum Centre, Melbourne. She completed her medical oncology training at Peter MacCallum Cancer Centre and subsequently spent 6 years at the Royal Marsden NHS Foundation Trust and the Institute of Cancer Research and Drug Development Unit, where she was responsible for designing, implementing, and supervising early-phase adaptive biomarker-driven trials. Over the course of her research career, Professor Sandhu has made important original contributions to cancer research, particularly in the development and application of the clinical biomarkers. She continues to undertake clinical and translational research in melanoma and other skin cancers. Our third presenter is Joel Fanning. Dr. Joel Fanning is a registered GP in Leongatha. His special interests include obstetrics, anesthesia, family medicine, and he is also a clinical editor for the Health Pathways of Gippsland. Now, I would like to pass on to Dr. Ma for her presentation.
Thanks very much for the introduction, and welcome to everyone who's joined us on the webinar tonight. I believe you'll be able to type questions as we go, and so we will hope to make this as interactive as we can and answer your questions as we go. And then if there's time at the end as well, we can answer questions then too. So we'll just get the slides in order. So I'm a dermatologist at the Alfred, at the Victorian Melanoma Service at the Alfred Hospital, and we'll go through trends in melanoma rates and early detection, risk factors, signs and symptoms, and the role of dermoscopy. So we'll have some clinical cases to look at tonight. We'll talk about biopsy techniques and what type of biopsy we should use for different lesions and when to refer. And then we'll talk about specifically melanoma management and your role as GPs in the care of patients with melanoma. Australia is the epicentre, unfortunately, of melanoma and skin cancer generally. We have very high rates of melanoma in this country, together with New Zealand, the highest rates in the world. We have over 14,000 new cases per year and close to 2,000 deaths per year from melanoma. And it's a very common cancer in the younger age groups. The cost of melanoma and skin cancer generally is high, and it places quite a burden on our health system. Skin cancer is one of the most costly cancers, in fact, to our health system. Melanoma makes up about $200 million per year in health costs. And then if you add another 70 million to that is the cost of additional biopsies for lesions that were thought to be melanoma but were not. Something to keep in mind. Melanomas account for about 10% of all cancers, and the incidence has been steadily increasing, although the good news is that there has been a reduction in incidence in younger age groups, and that's probably due to the implementation of sun-safe campaigns and preventive measures. So we're beginning to see improvements in melanoma rates in younger patients. There are a number of, so we're just getting a question there. Why does Australia have the highest melanoma rates since many other countries still have hot climates and lots of UV? Yeah, so I suppose we have a range of UV across the continent, the highest obviously being in Queensland, and a lot of fair-skinned people living in Australia, so the combination of fair skin and high UV is the issue, and obviously cumulative UV damage over somebody's lifetime will increase their risk. Sunburns and sun exposure will contribute to DNA damage causing melanoma. But and there's another question: why does Scandinavia have the second highest rate of melanoma? Yeah, so again, a fair-skinned population. Possibly people going on sun holidays and getting a lot of intermittent UV exposure with sunburns and so on, that will also increase the risk. So there's the cumulative UV exposure and then the intermittent UV exposure with sunburns as well. If we look at the rates, it's slightly higher incidence in males than females, and mortality, if we look at mortality, it's remained really quite stable over the years as well. Unfortunately, we're not seeing a reduction in mortality at this point in time, although hopefully that will change with some of the newer therapies that Shanine will speak to you about soon. And you can see if we break it down by age group, there's certainly an increasing incidence in males, particularly older males, more so than females. David Whiteman recently published this paper in the JRD that showed projected incidence by age group, and it looks like there is a plateauing of incidence, and you can see that reduction shown in the younger age groups there, but in the older age groups still the incidence seems to be increasing in Australia. So who is at high risk? Well, we know that if you have a past history of melanoma, you've got all the ingredients to grow a second or third melanoma. So a past history obviously puts you at high risk. The risk factors that we talk about commonly are atypical nevi, or what might be called dysplastic nevi, and that is a separate and independent risk factor to common nevi, which are the smaller moles that you might see. So on the slide there, you can see a patient with multiple common nevi, but also larger, what we would call atypical or dysplastic nevi. Having a history of non-melanoma skin cancer is also a risk factor, just as a marker that you've had a lot of UV exposure to develop other skin cancers. Having hair colour that is red and lots of freckles goes together with an MC1R mutation, germline mutation, and so that will put you at increased risk as well. And having a family history of more than one family member affected will increase your risk as well. And then obviously your skin phototype, if you aren't able to tan, if you burn easily, and if you've had a lot of sun exposure, are all things to be aware of when we're talking to patients about their risk. Dysplastic nevi, it's important to know what we mean when we talk about dysplastic nevi. They're usually the larger nevi that stand out. The clinical features are listed there. They often can have a slightly irregular or ill-defined border with some erythema often, but we wouldn't recommend excision of dysplastic nevi for prophylaxis. It won't reduce the risk. So these are indicators that someone is at higher risk, but removing them does not reduce the risk, because most melanomas will evolve as a completely new lesion rather than a change in a pre-existing lesion. We have different risk calculators to help calculate an individual's risk of melanoma. This is one that we developed at the Alfred, and people can log in. There's one for health professionals, and it gives a bit more information about different risk factors, and one for the general public as well. So some patients find that useful. There's one that was developed in Queensland as well, and there are a few now that are online, but these are two that you might find useful for your reference. So when we're seeing a patient and wanting to exclude melanoma, it's important, obviously, that we listen carefully to the patient's concerns and take a good history of anything that they're worried about. Examination of the whole skin. So it's really important to ask the patient to undress. I usually ask patients to undress down to their underpants or their underwear and provide a gown for them. I start from the top and work down, so I look through their scalp first and go all the way down to looking between their toes, and then they turn over and look at the backs of their legs and their back and so on as well. It's really important when you're doing this to be systematic about it. So you want to develop your own method of doing a skin examination that is thorough. It puts the patient at ease, and it also make sure that you don't skip around. Often patients want to point out something on the toe when you're starting to look at their face, but just resist that urge and have your own method of going through things systematically so that you don't skip over anything. It's really important to have good lighting and to use dermoscopy. So dermoscopy will improve our diagnostic accuracy quite significantly. We think about melanoma as being different subtypes, and that helps us really because the different subtypes have different clinical presentations and might have different morphological features, and we really want to recognise them early. So it's important to understand the different subtypes and how they might present differently and their different dermoscopic features as well. We think about radial growth phase melanomas that have often a prolonged phase of growing radially in the superficial layers of the skin in the epidermis first before they become invasive and grow vertically down to invade into the dermis. And so these are the radial growth phase tumours tend to be superficial spreading, lentigo maligna, and the acrolentiginous. And more vertical growth phase tumours, nodular and desmoplastic, can become quite thick quite quickly. And so it's a real challenge to try to diagnose them when they're thin and have an improved prognosis.
Just a couple of questions before we move on regarding the dysplastic nevi. So if we find that there is dysplastic, do we biopsy them or not?
Yeah, so if they're clinically atypical, it is actually quite confusing because you might get a pathology report back commenting on dysplastic nevi, a dysplastic nevus or dysplasia within a nevus. I'm talking about clinically atypical nevi. So they don't fulfill the criteria for melanoma, but they are larger moles and they have the features that we described previously. So those do not need to be excised. But if there are any features that are concerning for melanoma, then yes, they should be biopsied. But clinically atypical nevi, which I think is a better term than dysplastic nevi, don't need to be biopsied because they shouldn't have any features of melanoma. Oh. Yeah, they're just a risk factor in themselves.
Mm-hmm. Thank you.
Yep. So the radial growth phase melanomas do conform to the ABCD criteria. That is asymmetry, border irregularity, colour, variation and diameter, larger diameter. But of course not all melanomas conform to this. The radial growth phase tumours often don't. So it's important to know that. And we'll go through the radial growth phase tumours first though. So the superficial spreading melanomas are the most common, about 60 to 70% of cases. They're more related to that intermittent exposure rather than the chronic sun exposure and sunburns that we talked about. And so the age of onset is usually in the mid-40s. And they're more common on trunk in men and limbs, lower legs in particular for women. So this is a case here, and I think most people could probably recognise this as a melanoma. We'll go through some of the dermoscopic features in a moment, but these are some of the signs that you might look for on dermoscopy. So we talk about asymmetry of the pattern, of the pigment network. You can get a blue-grey veil, regression structures, a negative pigment net, multiple colours, multiple brown dots, and we'll have some examples of those coming up. So this is some dermoscopy of a superficial spreading melanoma, and you can see that blue-grey veil quite nicely in this case. You can also see some brown globules at the periphery, and you can see some milky pink patch in the to the right side, and multiple colours within that lesion there. So that's suspicious for melanoma. This lesion shows quite nicely some regression features. So regression features we see when there is inflammation that's come, an inflammatory process that's occurred in the dermis, and you get some scarring in the superficial dermis, and so you can see that scarring as a whitish change in the middle of that lesion there, and oftentimes you get some what we call peppering, which you can see some dustiness around that white area too. So that's often signs of regression features. This is an example of negative pigment net. So usually you would see, if you think about a lattice or a network, you would think about the darker structures as the pigment net, but this is where those that darker net has actually seen as a white lattice or white negative pigment network through that lesion, and that's often a sign of a superficial lesion. Blue-grey veil and irregular brown dots in this lesion. You can see the irregular brown dots. I'll see if I can point them out with the pointer actually. Does that work? No, so I think you can appreciate there, though, you can get some different colours throughout that lesion. There is some bluish colour coming through. There is some milky pink areas and some darker globules at the periphery. And the network that you might usually see, and you can see a hint of the normal network at 12 o'clock, but that's disrupted through the rest of the lesion. This is another lesion that you can see quite nicely. There's some blue-grey colour and milky pink, and you can see some white scarred areas in the centre of it, of the lesion as well, and around the periphery, more of the brownish network, but this was an invasive melanoma. So lentigo maligna is the in situ form of lentigo maligna melanoma. It used to be called a Hutchinson's melanotic freckle. They represent about 15% of melanomas and about only about 5% of melanoma deaths. They're very common. Lentigo maligna is a very common subtype, usually on the head and neck, the face of people who've had chronic cumulative UV exposure over their lifetime, so often in older patients. And the location on the head and neck makes it quite difficult surgically sometimes, because they're often in cosmetically sensitive areas and close to free margins and so on, making wide excisions quite difficult in some situations in this population. On dermoscopy, you get the fairly characteristic features of the perifollicular pigmentation. So you can see around the hair follicles there on the face, you get asymmetrical pigmentation and some features of peppering we discussed previously with some of the superficial spreading melanomas. You can get rhomboid structures and regression structures in these as well. This is a lesion on the scalp, and really sometimes on the scalp you will need to shave away some of the hair to see the extent of the lesion, but this was quite an extensive lesion which you could see much better having removed some of the hair, but some of that pinkish area too is also the melanoma, so it's important to look carefully in these cases. And we've outlined there where we think the lesion starts and stops, but difficult to see if you didn't expose the area properly. This is another patient who had a brown mark on her face for a long time and was reassured that it was a freckle, and then developed what she thought was a pimple within it, and it looked for anything like a pimple. But if you can see this on a this is a Woods lamp photograph. So this is taken with a blue light Woods lamp, and it really highlights the pigmentation quite nicely. And you can see there that there's that pigmentation. She would have had a Lentigo maligna for some time and then developed an invasive component to that later on. So important, and that Woods lamp is really quite helpful to delineate the margins of these lesions on the head and neck area. Sorry, I think that slide's frozen a bit. Great. Acral lentiginous melanomas, thankfully less common, but they can be very difficult to diagnose as well, and often are misdiagnosed as warts or callus or tinea. They often lack pigment, which can be really difficult and can be attributed to trauma, particularly when they're under the nails and so on. They don't arise from moles, they're not caused by UV light, and so they're got a different sort of mutational profile as well in that regard. Janine might talk about different treatment strategies, but these are cases you can see where you can understand why the lesion on the right might have been thought to be interdigital tinea. The one on the left is more obviously melanocytic, and that was a melanoma, an acral lentiginous melanoma. On the nail, you can get quite a broadened, you look for quite a broadened band appearing in the nail. You can get nevi as well with a pigmented band in the nail. Typically, they're quite narrow bands and nice and regular as well, and stable over time. So when they become broadened and become irregular with different colours through them, they're certainly concerning and warrant biopsy. We'll talk about biopsy technique for these lesions in the coming slides because they're quite difficult. Again, on dermoscopy, there are some specific signs that we look for. So we look for the furrows and the ridges. And if you have pigmentation in the furrows, that's normal. But when the pigmentation is going up onto the ridges and surrounding the eccrine ducts, that's abnormal. So the melanoma is probably coming from surrounding the eccrine ducts, much like on the face when we look at Lentigo maligna, you can see pigmentation surrounding the hair follicles. So if that helps you to remember, the pigmentation on the ridges around the eccrine ducts is a sign of melanoma. The pigmentation bands, as we talked about in the nail, usually varying in width and different colours, and there can be nail dystrophy as well as a later sign often, and pigmentation going up onto the the proximal nail fold, which is Hutchinson's sign. So this is involvement of the ridges around the eccrine ducts. You can see a few eccrine ducts up the very top of that lesion, about 12 o'clock, and quite a dark ridge pattern. So this is a desmoplastic melanoma. This is often they present as scarred area, scar tissue, quite firm. They can be mistaken for dermatofibromas. They can grow quite quickly and also can arise in a pre-existing Lentigo maligna as well. This was a desmoplastic melanoma, and unfortunately in some of these cases it's really difficult to see many features on dermoscopy. So dermoscopy often is not particularly helpful in these cases. Sometimes you can see some subtle pigment, but not always. This lesion was punch biopsy. That's the scar you can see in the middle. This lesion, is it a melanoma? It looks very similar to the previous, and this is the dermoscopy, and the dermoscopy is also fairly similar. But this was actually a dermatofibroma, so benign lesion. The history obviously is a telltale thing. This had been present for years and was stable. Nodular melanomas have quite rapid vertical growth from the outset. They account for about 14% of invasive melanomas, but account for a large number of deaths in the state because they tend to be quite thick when they're diagnosed because of their rapid growth. They can have quite an atypical presentation, so they can be difficult diagnostically, and oftentimes patients themselves are not aware that it's a particular lesion of concern because it just doesn't look like what they would imagine a melanoma to look like. So high case mortality from these lesions. These are the ones that we need to try to recognise a little earlier. So this is one case, and you can see that there is some pigmentation in this lesion and some ulceration on the surface as well. It's actually quite unusual to have a completely amelanotic lesion. So the pigmentation around the periphery is a real hint here, and the ulceration is concerning, obviously. This is a nodular melanoma. It's got some blue-grey veil, and you can see some white structureless areas and some irregular vessels there. When the lesion gets thick, the vessels tend to get larger diameter and irregular, atypical. This has some ulceration as well, this lesion. This is another example that you might mistake for an angioma, but you can see multiple colours there and some pink, milky pink areas as well, and some subtle pigmentation at 12 o'clock. So elevated ferment growing needs to be added to the ABCD criteria because anything that is changing over time, and particularly if it's firm, if it's concerning growing for more than a month, it should be excised. Inflammatory lesions can come and go and usually will resolve themselves over the period of about a month, but if it's not behaving like that, it needs to be biopsied. So practice points for managing these lesions. How suspicious are you for melanoma? If you are, really, you're obliged to excise the lesion if possible, and there are some instances where that's not possible, and we can discuss that. If you're not comfortable to excise it, that's fine, but do refer urgently and call to make an appointment with somebody who will be able to do that for you. Borderline lesions that are flat and you have low suspicion, don't feel any diagnostic criteria for melanoma, can be monitored over the short term, usually 3 months, with a photograph, so a macroscopic photograph as well as a dermoscopic photograph. And lack of change is reassuring. And if there's really no suspicion for melanoma, you can reassure, but always counsel a patient that if there's any changes, then they need to return. So if there's any dermoscopic signs of invasion, really the lesion does need to be excised. If a lesion is raised, we really shouldn't be monitoring these lesions. If it's raised and there's a suspicion of melanoma, it really should be biopsied or excised or referred.
One of the questions is, what's the time frame for short-term monitoring?
Yeah, it's a good question. So usually 3 months is a good guide for most lesions. Nails, if there's a bland, narrow pigment band on the nail, you might monitor it over 6 months. And often people might come in with some hemosiderin under the nail that's blood from trauma that you might photograph and again check again in 6 months' time. So,
and if there is no change in 3 or 6 months after that, do we need to still keep them on monitoring?
So it depends their risk. So people who are high risk for skin cancer in general, they might be seen in 12 months' time or sooner if they're getting lots of skin cancers. But if they're otherwise low risk, then they can monitor things at home. It's nice if the patient has a photograph themselves that they can look at if they're worried about it changing and ask them to come back if they're aware of anything. And it's good to just educate patients that they should know what's on their own skin, that they should get used to checking it themselves. We recommend that the change of each season to check their own skin just to make sure there aren't any new or changing lesions of concern, and to come in to see you if there is anything that they're worried about. Okay, so some tips on learning dermoscopy. There are some books here and some courses that I've just mentioned there that are useful if you're interested in learning dermoscopy, but it's really, it's a handy thing to be able to do in clinic. So what to do if a lesion is suspicious for melanoma: biopsy to confirm the diagnosis. We might go through this a little bit quickly, but how do we confirm the diagnosis? Well, a 2 millimetre narrow margin is appropriate. We want to avoid any flat closures or unusual closures. We just want a primary closure on the primary lesion, because that will enable us to do further staging, such as sentinel node biopsies, if that's appropriate in the future. There are some lesions, obviously, where it's not appropriate. So on larger lesions in special sites such as the feet and so on, it would be difficult to do an excisional biopsy. So there are some, so punch biopsies are used occasionally in these situations to get an adequate assessment of depth for a large lesion that is obviously melanoma. But if it's an equivocal lesion and you're not sure, a partial biopsy is not recommended because of the increased risk of a false negative diagnosis, particularly with punch biopsies more so than shave biopsies. So the false negative diagnoses are problematic, and we do see sampling errors, and also very difficult for the pathologist to interpret. So do think about what you're sending off to the pathologist and try to give them all the information that they need on the pathology slip, and also an adequate representation of the lesion. So if it's an equivocal lesion, they need to see the whole lesion to be able to make an adequate assessment, really. So this is a case example of a young patient who had a nevus on the calf that she'd been worried about, and had a 2 millimetre punch biopsy of the lesion, which was read as benign. It then continued to change, and it was then excised a few months later, and was quite a thick nodular melanoma with a few mitoses in it, and she already at that stage had groin lymph nodes. So that was her PET scan, and unfortunately she had quite extensive pelvic disease, and went on to have systemic therapy as well. But just an example of how a punch biopsy is not often representative and can cause trouble down the track. So if something is able to be excised, do excise it. Shave biopsies have very high rates of base transection. So again, they will be appropriate in some situations. So shave biopsies are very good for lentigo maligna on the face, and in situ lesions they can be very appropriate for, but not appropriate for anything really that looks to be invasive and could otherwise be readily excised. So we are seeing an increasing trend of use of shave biopsies in the state, which does cause problems with staging inaccuracies. And Janine will go through some of the new treatments that are available, and it's really important to be able to stage patients accurately now, so that they do have all treatment options available to them. So getting the tumour microstaging correct is the first part of being able to do that. I'm just going to skip over some of this so that we can get to sentinel node biopsy, because it's really important for you to know when to refer. Sorry, can you just... Yeah, so these are difficult lesions where you might do an incisional biopsy by removing the nodule, the thick nodular part, for instance, the lesion on the neck on the left. The lesion on the heel there, you might do a punch biopsy through the tumour to get some tissue, and there's obviously a punch biopsy taken from that desmoplastic lesion we spoke about before. Nails are very difficult. You have to actually get to the nail matrix, which is hidden under the proximal nail fold, which means retracting the proximal nail fold. If you biopsy the actual nail plate, you won't get the information that you need. So these, I think, are best referred. They're difficult biopsies, and they're actually very difficult to interpret by the pathologist as well. So I think nails are a good one to refer. We'll just talk about re-excision. So in situ melanomas should have a 5 mm margin. And when we talk about a wide local excision, we like a 5 mm margin. For invasive melanomas, we like at least a 1 centimetre margin. But I've just put a little reminder here. So if you have a melanoma and you've excised it and it is a millimetre or more in thickness, you do need to consider the patient should be considered for a sentinel node biopsy prior to the wide local excision. If their melanoma is more than 0.8 millimetres, so between 0.8 and 1, and it has other poor prognosis features such as ulceration or mitoses, they would also be candidates for sentinel node biopsy, or at least a discussion about this. So it is best to refer these, and the sentinel node biopsy needs to be done at the time of wide local excision. So if they've had their wide excision already, it is difficult to do the sentinel node biopsy because it will have a higher rate of false negative sentinel node because it messes up the drainage, the lymphatic drainage. So nodal staging is important because it does open up treatment options for patients. If the node is positive, we will be able to offer, in many cases, what's called adjuvant medical therapy in the form of immunotherapy or targeted therapy that Janine will discuss with you. It's important to be able that the patient understands what the chance is of having a positive sentinel node, and this will be greater with a thicker tumour and if it's ulcerated as well. And so I've just outlined some of the figures there that you can refer to, and these are all in the new Cancer Council guidelines on the Cancer Council Australia wiki page that you can refer to as well. So if it is positive, if the sentinel node is positive, then really the patient should be presented in a multidisciplinary setting. There is no longer an indication for complete lymph node dissection because there has been shown to be no survival advantage with this more morbid procedure. But certainly we would be referring these patients on to our medical oncology colleagues, and I'll let Janine talk to you about adjuvant therapies in the next talk. So staging is really important because it gives us an idea of prognosis. Breslow thickness is one of the most important prognostic factors. And it's important when you're discussing this with patient that you don't get mixed up with Clark level. A lot of patients come in and they're terrified that they've got a Clark level 4 melanoma and that they're going to die because they've got this mixed up with stage 4 distant metastatic disease. So do be aware of the difference between Clark level and the stage of melanoma. So stage 3 is when it's gone to lymph nodes and stage 4 is when they've got distant metastatic disease. Prognostic information, these are 2 websites that are helpful. You can plug in the patient's information, the tumour characteristics, and it will give you information on their prognosis. And that's quite easy to navigate, and it will give you 5- and 10-year survival curves there. And the new staging, AJCC staging guideline criteria, this has changed. So this changed last year. And it takes thickness into account for stage 3 disease. And so that's important to be aware of as well because it does change who we can, how we manage these patients, particularly with medical therapies, as Janine, I'm sure, will outline. So it's important to know who sentinel node biopsy should be offered to, so that is based on the thickness. And following sentinel node biopsy and so on, we would consider scans for patients who have stage 3 disease and above, and stage 2C disease too, so that's very thick ulcerated tumours. But that is something that can be discussed at a multidisciplinary, in a multidisciplinary setting, or we're always happy to receive a call about any staging investigations. Blood tests are not usually indicated for any early stage disease. We might skip over the case because I think we've only got a couple of minutes left, but just planning, follow-up and surveillance. Okay, the peak risk period for occurrence is in the first year or two after the treatment of stage 1 to 3 melanoma, and at least 80% of recurrences occur within the first 3 years. So this is really the time when we need to be a little bit more vigilant with surveillance visits. And the risk of the melanoma, the primary melanoma, recurrence does decrease with time. However, the risk of getting a subsequent primary increases with time. So really these patients do need lifelong follow-up. For thick tumours, obviously the visits will be more frequent, 3 to 4 monthly. And for thinner tumours or in situ melanomas, it might be once a year. But that will be dictated to a degree also on their other risk factors as well. So I've got some suggested follow-up intervals there, and no evidence for routine surveillance imaging for stage 1 to 2. In most centres, surveillance imaging is routine for stage 3 melanoma now because of the adjuvant therapies and new treatments that we have available to us. Surveillance across the risk group. So if patients have a particularly high risk phenotype with lots of moles and dysplastic nevi, then I think they should be offered total body photography for surveillance, and that'll allow us to detect change early. And so these are the people that might benefit with lots and lots of moles. And sequential digital dermoscopy is more specialised, but essentially using dermoscopic imaging and following those to pick up very early dermoscopic changes. And there's some illustrations. We are getting some new 3D imaging capabilities at the Alfred and then other centres throughout the state. So do look out for that. We'll be able to offer patients high resolution imaging in the future and be able to help you out with this as well with new technologies that are coming to light. So these are some numbers to be able to access that for your patients. There is just their referral details if you need it for any confirmed melanoma cases. I don't know if we've got time for questions.
No, well, thank you, Professor Mao. We do have time for questions at the end.
Mm-hmm.
Participants. So Professor Mao will be around towards the end of the session to answer your questions.
Yeah, I just see. I just see one question about advice over the phone, which the phone number's up there. So hopefully that's helpful.
Thank you. All right. So we do have a couple of poll questions to understand the participants better. I'll just put the first poll question on the screen before I call on Professor Shandu for her presentation. Okay, the first question is on the screen. If you can answer that, please. All right, we've got 91% of representation from GPs and 9% with the other. Thank you, thanks a lot. And we will go to the next part of our presentation. And the second presenter is Professor Shahneen Santu. Welcome, Dr. Shanta.
Thank you.
Just getting the screen up online. All right.
Just move down. This one. Well, thank you. So today I'm going to be talking about immunotherapy specifically in the context of managing cancers and in particular melanoma. So at the heart of it is the T cell. So in the 1980s and in the 1990s, someone by the name of Jim Allison, who's now got a Nobel Prize recently, noted that in fact the best way to make the immune system attack cancer is to actually eliminate some of the breaks in the immune system. You can imagine that we have lots of checks and balances in the body in relation to in relation to the immune system, and for a long time people focused on trying to rev up the immune system, and that actually failed in terms of attacking the cancer. So Jim Allison and basically found that by actually eliminating some of the breaks, we are able to upregulate the immune system to attack the cancer. And at the heart of it is the T cell. And T cell receptors are those receptors that are actually able to facilitate the T cells to start to attack a cancer. And how they do that is that the T cell actually recognizes a tumor antigen. And the reason it recognizes a tumor antigen is that the tumors look slightly different from us. And when they look different from us, the immune system is therefore able to recognize them as being foreign or undesirable, and hopefully therefore attack them. And harnessing the immune system with immunotherapy makes those T cells work harder for us to attack the cancer. Okay, so there have been two T cell immune checkpoints that are the poster children of immunotherapy. The first is called CTLA4 and the second is called PD-1. And both of them you can think of as molecular breaks. And essentially what they do is they come in and they break and they modulate the immune system to regulate the immune system so that the immune system doesn't keep being revved up. So CTLA4, as you can see there, they've got a dendritic cell presenting a yellow blob, and that yellow blob you can think of as a tumor antigen. So the dendritic cell is trying to educate the T cell, the immune cells in the body, about what the cancer looks like. And so that the dendritic cell is presenting the tumor antigen as in conjunction with the MHC class molecule to the T cell. But you can see there that as the T cell is being activated with those plus signs there, the T cell has got a homeostatic mechanism, and it starts to upregulate something called CTLA4, which serves as a brake to dampen down that T cell from being fully activated. So you can imagine if you can come in with an antibody, an anti-CTLA4 antibody, you can block that interaction between the dendritic cell and the T cell, and therefore that T cell that was now being dampened down by its own homeostatic mechanism is basically allowed to keep becoming activated. So hopefully this is what you're trying to achieve with ipilimumab, by blocking that interaction between CTLA4 and B7, that interface between the dendritic cell and the T cell. Hopefully, once those T cells have been educated about what the cancer antigens look like, hopefully they travel to the right site, which is within the tumor itself, and at the level of the tumor, what becomes more important is actually PD-1. So you can see there the T cells been educated about what the tumor antigen looks like, that yellow blob, and it's recognizing it on the tumor. But the moment it starts to recognize it, cancers know how to evade the immune system. And so what happens is the cancer upregulates what they call PDL1 and PDL2. And PDL1 and PDL2 are ligands that are commonly found on cancers, and they dampen down those immune cells. I often give my patients an example, about the fact that the cancer puts a shield so that the immune cells, even though they are there, sometimes they don't actually see the tumor itself. And what PD-1 blockade does is, you can see an antibody comes in and it blocks that interface between the T cell and the tumor cell, so that it basically blocks the negative regulation of the T cell. And so if the T cell managed to get into the tumor microenvironment, it's got a good chance of attacking the cancer. So the reality is, although CTLA4 and PD-1 inhibitors are the ones that have made their way into the clinic for melanoma and renal cancer and a whole heap of other cancers, there's a whole host of other immune checkpoints, of other breaks, or where where there's the cells in the body, particularly the immune cells, talk to other immune cells and as well as other structures in the body. And what is happening in the clinic currently is we're working this out, and there are many agents that are currently in the clinic as part of the development of this new therapeutic strategy for cancers. So for the first drugs, in fact, to make immunotherapy successful after many years of trying was a drug called ipilimumab, or an anti-CTLA-4 antibody. And this is basically a couple of trials that were pivotal trials in melanoma, which compared ipilimumab, this new anti-CTLA-4 antibody, against chemotherapy in the upper graph, and in the lower graph actually compared it against a GP100 vaccine. And what you actually see, which is very interesting, is the fact that even though the response rate, so that OR, which is objective response rate, so we in medical oncology, we use response rate to define how much the cancer has shrunk. So you can see that with ipilimumab, the response rate is only 10%, it's not very exciting at all. Versus chemotherapy, where the response rate was pretty low, and at about 10%, and with the vaccine it was 10% versus 1.5%, and you wouldn't really get all that excited about a response rate of 10%. In fact, sometimes chemotherapy can produce response rates of about 10%. But what was intriguing was the fact that there is a plateau to the curve. So if you have a response, or in fact, if you don't have a response, but you even just have a stabilization of your disease, then you're likely to become a long-term survivor. So you can see that even though the response rate is in the range of 10% to ipilimumab, the 3-year overall survival, the patient surviving at 3 years is in the range of 25%. And what is interesting is if you survive at 3 years, you probably survive at 4, 5, 6, 7, 8, and now 10 years. So if you turn up to have a response, or in fact even stable disease with some of these immunotherapies, actually you can be a long-term survivor. What about PD-1? So PD-1 inhibitors, as I told you, CTLA-4 was basically activating the immune, targeting CTLA-4 activates the immune system all over the body because it's acting in the periphery. But when you target PD-1, what you're trying to do is remove the brakes of the immune system that is trying to see the cancer. So you can think of the immune system recognizing cancer cells, but they get shut down when they get to the cancer cell, cancer microenvironment itself, by the PD-L1 ligands that are found within the microenvironment itself. And if you block that with the PD-1 antibody, what you do is you enhance the activity of the T cells that are within the tumor microenvironment. And these drugs have really been a game changer for melanoma, but they've also been a game changer for lung cancer, renal cancer, bladder cancer, and a whole host of other cancers. So here are some survival graphs of nivolumab in orange versus dacarbazine, the old chemotherapy that used to be used that never really shown an improvement in survival. And you can see that nivolumab certainly improved survival with a hazard ratio for death of 0.42. So that's a very marked improvement in survival. Towards the left hand of the slide, you can see what we call waterfall plots. And waterfall plots really measure the drop in we measure the tumor size, and if they go up, which means that the patients haven't responded and the tumors have grown, then actually you see that the target lesions for the patient increases, and if they go down, you see that actually the target lesions have diminished. And what you can see from these waterfall plots is actually with nivolumab, which is an anti-PD-1 inhibitor, more than 50% of patients, in fact closer to 60% of patients, will have a decline in their tumor volume. And as I said to you before, with the ipilimumab, you can see that if you have a decline, or in fact, even if you just have stable disease, that means it's not growing, there's a good chance that you are going to be a long-term survivor. So that's remarkable. And we can see here that the objective response rate for PD-1 inhibitors, nivolumab, is in the range of about 40%, and the 1-year survival, particularly in this, when this study was presented, was 72%, as opposed to the historical control. Patients used to most patients with metastatic disease used to die within 12 months. So
you can see from here, I've highlighted that the complete response rate, meaning that when we look at the scans, all the disease has disappeared, is in the range of 7%, partial response 32%, so about 40-odd% of patients responding well to treatment. But as I highlighted before, with these treatments, even stable disease means that the patient has now got a homeostasis that has been established between the immune system that is able to continue to recognize what the cancer looks like and keeps it in check. So those patients do just as well. So what about pembrolizumab? So pembrolizumab is another PD-1 inhibitor that you'll see some of your patients on, and you can see that from the waterfall plots that pembrolizumab performs just as well as nivolumab. Again, with the response rate, study to study, it varies, but the objective response rates, meaning that somebody has had a complete response where all the disease has disappeared, or a partial response where actually the disease has shrunk by more than 30%, is in the range of in the range of 30 to 40%. But up to about 60% of patients will have clinical benefit, so all the patients with stable disease or a partial response. So again here, just highlighting the fact that these drugs are not without side effects. 70 to 80% of patients receiving PD-1 inhibitors will actually have side effects, but the vast majority of those side effects are actually things like fatigue and rash and itch, which are mostly manageable. The incidence of what we call grade 3 to 4, so grade 3 meaning severe and grade 4 meaning quite severe and sometimes requiring hospitalization, does occur, and that occurs in about 10 to 13%. And we'll talk a little bit more in the upcoming slides about some of those side effects. I put up this slide just to sort of make everyone aware that these drugs are here to stay. There is a range of different PD-1 inhibitors that have made their way through and have in fact in Australia been approved for melanoma, lung cancer, head and neck cancer, urothelial cancers, and I have no doubt that in time most of cancers will be managed with immunotherapy in some shape or form. And just to again highlight, in other cancers, we are seeing the same sort of survival curves as we've seen with melanoma. So I here highlight some survival curves showing in the top curve PD-1 inhibitors versus chemotherapy, both for lung cancer as well as for urothelial or bladder cancers as well. Okay. This is a presentation that is actually a couple of years old now, but I thought it would be useful to try and understand what the patient's journey is. And in fact, this was the phase 1 study this was the phase 1 study that enrolled 655 melanoma patients. Phase 1 studies are often small, but this study in fact enrolled a substantial amount of melanoma patients and in fact led to the registration of pembrolizumab for Australian patients thanks to some of the political will of some of the patients that had melanoma. And what we find, sorry if you could just go back to that slide. So what we find, which is intriguing, is the fact that you can see that at that 36 month, 40% of patients are actually alive as compared to historical control where, it would be in the range of 5% or less. And in patients who've actually had prior therapy, in fact, who have not had prior therapy, that number is in fact higher at 45%. Okay, I just want to basically highlight, so this was a study that gave patients pembrolizumab. Pembrolizumab is given every 3 weeks, and this was given to patients. And, sometimes patients who have a complete response get sick and tired of coming into hospital every 2 weeks or every 3 weeks for an infusion. And so these patients essentially asked their doctors, can they stop treatment? And so what happened was the pharmaceutical company allowed patients to stop treatment after 2 years, and that has actually generated some data because, of course, these are new drugs, and we don't really know, to be perfectly honest, how long do you need to treat a patient to actually achieve the sort of responses that you want to.
One of the questions from the audience is, what's the cost involved with the medications?
Okay, so basically these are incredibly expensive drugs. So the cost of if somebody were to self-fund pembrolizumab or nivolumab, if it wasn't approved on the PBS, one dose is in the range of about $5,000 to $6,000. And you can imagine if you're giving the patient one of those doses every 3 weeks in a very short space of time, it's costly. I would say that most cancers will tend to respond within about 12 weeks. So if you're taking the approach that I'm going to try something to rev up the immune system and I can't get PBS funding for this, and the patient is self-funding it, then, sometimes you give them about 16 weeks to see whether it's working or not, but it is incredibly expensive. We're very fortunate in Australia that we have a very good system. I think the PBAC does a terrific job of actually looking at survival data and making good decisions, and we're very fortunate to have access to these drugs for cancers.
That's really good to hear. Yeah.
So I wanted to highlight this slide because I think it gives you a sense of what happens to patients and their patient journey. So this is called a swimmer's plot, and each line is one of those patients who basically decided that they would want to come off treatment. And so that's their journey being mapped out in months on the x-axis. And of course, each of those lines is a single patient. I just want to highlight those yellow blobs are in fact the first time point where actually a patient had a response. So you can see that with these drugs don't take months and months to work. Often a patient will have a response within 12 to 16 weeks of treatment. And you can see that those yellow blobs in many instances actually become blue blobs, so meaning that a partial response actually can over time deepen and become a complete response. So someone's cancer can continue to diminish in size to the point that you can't see it on the scans. And you can see that most of those changes, if they're going to occur in the first year and in the second year. So in this graph, many of the patients actually stopped treatment after 2 years, and that's highlighted there in the lighter yellow. And you can see that many, in fact, almost all, except for 2 patients in this graph, essentially remained that their disease continued to respond despite the fact that they stopped treatment at 2 years. Of course, the follow-up is very short, but we are increasingly having conversations with our patients about perhaps the value of stopping treatment once they have hit that 2-year mark.
Mm-hmm. That's right.
I just want to show you what we see in the clinic, which is very exciting when we see these responses. So here are pictures of one of my patients with, as you can see, extensive disease in the liver. So this is a PET scan showing extensive disease in the liver, in the nodal disease in the mediastinal area, up in the neck, extensive disease in the bone. So really horrible disease. And often these patients have a poor ECOG performance status. They've got a lot of symptoms, and previously we would have thought that these patients would do badly. And in fact, early on in the first 12 weeks, while we're waiting for the treatments to actually respond, we really have to give the patients a lot of support because, of course, we don't know whether the patient is going to be a responder or not respond. And as you can see here, here's a patient actually, the time frames, the patient actually had started to have a response within about 3 months, and it's now 48 months, and you can see the patient is free of disease, and we've stopped the treatment for this particular patient.
One of the questions asked is, while the patients are on immunotherapy, is there chances of other forms of cancer or tuberculosis for the patient?
Okay, so we certainly have not seen any tuberculosis, or actually, in fact, my patients say they don't get as many colds. I don't know whether that's actually true or not. I have seen things like some skin lesions disappear, whether those are benign skin lesions, or so certainly some skin lesions can disappear. But in terms of TB, and other sort of, it is not suppressing the immune system. In fact, it's actually revving up the immune system, so it should not actually cause tuberculosis. We've not seen that. There are some reports of reactivation of hepatitis that is starting to emerge. So, certainly these are more of an issue in certain countries where hepatitis B is common, like Taiwan and Korea and places like that in China. And so being aware that there is a possibility in actually putting people on antivirals while you've got them on these drugs is useful. But we've not really had any concern with TB.
Thank you.
So this is basically just another slide to show you, those responders, and it's so gratifying in clinic to see these patients because they are starting to think about having children, and they're working, and I have patients running marathons, having actually brain metastases 6 years ago, and children and women trying to become pregnant now, and of course it's a whole new area that we're dealing with.
It's very effective.
Correct. So in terms of side effects, again, just to highlight, any grade side effects, meaning any sort of side effects, occurs in about 83%. So that's almost all patients. But grade 3, 4, meaning severe, occurs in about 10 to 14% of patients. And I wanted to just sort of highlight the sort of side effects that we tend to see. We see with PD-1 inhibitors, hypothyroidism and hyperthyroidism. I would say this occurs in about sort of 8 to 10% of patients. Often the patient will have a period of hyperthyroidism before they burn out. That happens quite quickly, and then we tend to give them supplements. Colitis is inflammation in the bowel. This requires recognition, and we rely on our patients to tell us if they've got diarrhea. Hepatitis, now this can be life-threatening. Again, we're very vigilant about this, and often if you come in and treat the patients with steroids, you often can get on top of it. Hypophysitis or hypoadrenal situations can occur, and you really have to have a very low threshold of actually doing the test to investigate. So we tend to have a system in place where prior to every dose of treatment, patients tend to have a battery of blood tests so that we can keep an eye on all these things. Pneumonitis can actually present with shortness of breath, but to be honest, by the time a patient presents with shortness of breath, it's pretty severe. Often these patients with these immune side effects will often present with constitutional symptoms that you can't quite account for. And I just want to sort of point out, one of the things we're starting to learn about the immune system and responses to immunotherapy is that they may be less to do with the cancer and the host, and they may be more to do, in fact, with the microbes that live in the patient's gut. And so one of the things how patients can present with immune-related side effects is they can have fevers. And so I just sort of advise caution when we think about antibiotics for these patients. There should be good reason to give them antibiotics. More common side effects are things like fatigue that occurs in about sort of 16–20%. It's not profound, it's not like chemo fatigue, but we would recommend exercise for those patients. You can have various levels of diarrhea, but to be honest, I treat any diarrhea seriously. Rashes are pretty easy to manage with topical steroids, and the skin often does become a little dry and itchy, so moisturize is good. Asthenia and nausea are, asthenia is hard to manage, but nausea is easy. Arthralgias, again, are fairly straightforward to manage, and vitiligo, certainly in melanoma, we think is a good thing. Okay, so if one drug works well, why not combine two? And certainly there is data. Of course, ipilimumab and PD-1 inhibitors, whether that's nivolumab or pembrolizumab, work at both ends of the immunotherapy axis, so why not combine it to rev up the immune system? And certainly there's been data to suggest that the two work together well in preclinical models, as well as heightened response rates. So moving from, I told you before, a response rate of 40% with PD-1 inhibitors to about 60-odd% with the combination. Next slide. And you can see here, I just wanted to highlight that so that we've shifted that waterfall plot. So almost 3/4 of patients will have a decline in their tumor volume, and quite a substantial percentage of patients actually have a marked reduction in their tumor volume. And in fact, at the left side of that curve, you can see many patients, in fact, have a complete response. But next slide, sorry. So you can see here complete response rates, meaning can't see the cancer on the scan, is 17%, partial response 40%, stable disease. So as I said, stable disease with immunotherapy is also a good thing. So 3/4 of patients benefit. Next slide. Unfortunately, of course, if you have now removed, these are progression-free survival plots. In orange is the combination treatment. So you can see that at 2 years, 43% of patients are actually have not progressed, as opposed to the single agent PD-1 at 37% and ipilimumab, the CTLA-4 inhibitor, at 12%. Next slide. And likewise, you can see that there is a marginal survival benefit for the doublet over and above single agent PD-1. And it would be very nice to know which of the patients actually need the doublet and which of the patients only need the single agent, because these drugs are not inexpensive and they also cause a lot of trouble in terms of immune side effects. Next slide. So just want to highlight, any grade side effects actually occurs in 95%, so you can just about count on your patient having a side effect. 40% of patients stop treatment as a consequence of, slide before. 40% of patients actually stop treatment as a consequence of treatment-related side effects. And it's interesting that of those 40%, 70% of patients actually have a good response. So these are not without significant side effects. Next slide. And I just want to highlight for the single-agent PD-1 inhibitors, so for example, gastrointestinal side effects is about 2%, it goes up to 14%, hepatitis from about 2% to 18%, endocrine toxicities from 14% to 30%, but mostly those are grade 1 and are easy to manage. Next slide. Okay, I'm just going to provide some cases. We're going to run through these very quickly. So that, you know, as I said, rashes are fairly easy to manage, but this is toxic epidermal necrosis. It's life-threatening because very rarely, probably 1 in about 800 patients. Next slide. This is a patient who's had bullous pemphigus, my first and last patient with pre-existing bullous pemphigus who I gave immunotherapy to. I don't think I will do it again. Learning curve, the patient actually came in with this very large bullae and spent 2 weeks in hospital needing to recover from that. What about endocrinopathies? So next, so this is actually a patient who turned up in clinic just feeling tired and having a bit of a headache, and they happened to have their staging scans, and so in fact that was very helpful. It made the diagnosis for us. They had an enlarged pituitary gland, and we then subsequently did the endocrine axis, and as you can see, the TSH is diminished, cortisol is low, in keeping with a hypopit condition. And this is the graph sort of showing that very rapid decline in the thyroid function. Next slide. This case I highlight is basically a young man, man in his 60s with melanoma. We initially had 1 dose of ipilimumab. You can see the tumor there in his chest as well as in his gluteal region on the initial PET scan on the top. He progressed after he progressed in the bowel and required a hemicolectomy because of a tumor deposit, and then it continued on with 4 doses of ipilimumab but progressed, and subsequently had pembrolizumab, a PD-1 inhibitor, and after 2 doses, he presented with polyuria and polydipsia. Next slide. Okay, and you can see there he actually got diagnosed with type 1 diabetes. This is 1 in 800 patients, very rare. The diabetes often is very brittle. Next slide. And he remains in remission. Next slide. Okay, this is basically another case of somebody who, do you mind if I move it? Oh, yeah. So somebody who actually presented to Geelong with after 4 doses of treatment with fever, lethargy, drowsiness, confusion. You can see that they're all very constitutional symptoms and an elevated lithium level. Nothing specific. Those are the bloods initially. Again, a bit of renal impairment, lithium levels, albumin low, and the differential diagnosis was perhaps sepsis or lithium toxicity. They were appropriately treated with ceftriaxone and essentially then got transferred across to Peter MacCallum. And there, the antibiotics, the assumption was it was a chest infection because, well, the patient was constitutionally unwell. They had a fever, but in retrospect was probably inflammatory rather than infective. And the patient essentially continued to decline. It was very hard to get an MRI. The patient essentially had was very drowsy. And ultimately somebody tweaked and did some bloods and found, in fact, the cortisol level was low. They got treated with replacement, but despite the replacement with steroids, essentially they continued to decline and died. This was probably the first and last case of a patient dying at Peter Mac as a consequence of this problem. And essentially they had a postmortem which showed autoimmune hypophysitis and bronchopneumonia, and essentially the patient was free of disease. So I suppose I just want to highlight that these drugs are highly effective, however, they're associated with considerable toxicities. I have, shall I keep going or not? 2 minutes. Okay. I just to highlight a couple of other important things to remember. So colitis is one of the things that can cause perforations in the bowel. It occurs in 1% of patients. So it does require vigilance. And if somebody has got bad diarrhea or a change in the bowel habit, it's important to actually get them to come into the hospital. So this is a patient who presented with diarrhea, got admitted to hospital, had steroids appropriately. The bowel counts, in fact, improved, but they were on discharge, and in the context of weaning the steroids, they represented with recurrence of the diarrhea again, and essentially had blood in the stools, got recommenced on methylprednisolone, and mycophenolate, and you can see the bowel was all nice and thick in keeping with inflammation, and the patient perforated. And that's essentially what their bowel looks like. And despite appropriate treatment, there's ongoing inflammation in the bowel, so many, many months down the track. So I think, again, just a message that, there should really be a low threshold to investigate patients who've actually got some of these side effects. I'm going to skip to my last couple of slides just to sort of apologize that we see a whole heap of different side effects with these drugs. But I'm just going to skip to the last couple of slides. Victoria alluded to this, that the reality is these drugs that have shown an improvement in survival in the metastatic setting have now moved into the adjuvant setting, meaning that we're taking these drugs earlier in the treatment paradigm for patients. And so we think this is a good way to cure melanoma, but of course it's associated with more side effects. And we need to have a partnership and vigilance to manage some of these side effects. Okay, just also wanted to highlight that the grade 3-4 side effects also increases when you give patients these treatments earlier. So again, requiring more vigilance. I think basically my summary is that immunotherapy is very effective, certainly for melanoma, but not all patients respond. And so we have to balance, how we support them through it as well as manage their side effects. Many patients experience side effects. We need to define better ways to pick the patients that are likely to have side effects and are likely to respond to these treatments. It's often that they're more effective in patients with small volume disease. Patients are often complex. Adverse events are very subtle. They're often missed unless you're actually looking out for them. I would say, don't have the antibiotic reflex. If somebody's on immunotherapy, think twice about whether it is in fact infective, because it will have an impact on the microbiome. There's studies that have been done to show that even antibiotics from a couple of months for a dental infection or UTI can actually affect the microbiome and be associated with diminished responses to immunotherapy. Immunotherapy can be associated with side effects in any organ, including bowel, liver, lung, heart, just about everything. And my final slide is the fact that there needs to be education, both doctors, nurses, and patients. There needs to be engagement with GPs, and I don't think we've quite gotten there yet, so very grateful for this opportunity. I think there need to be better guidelines as well in broader education. Thanks.
Thank you, Dr. Sundar. Before I call upon Dr. Fanning, I would like to put our second poll question. Of course, Dr. Sundar will be around to answer some of your questions towards the end of our presentation. Okay. So the second poll question is on the screen. Can you please answer that? All right, now I would like to call Dr. Fanning for his third presentation.
Thank you very much, and thank you to Professor Sandhu and Professor Ma for their really interesting presentations. That was great. So here.
Yep.
some melanoma gold from a dermatology and oncology point of view, which was really interesting from my perspective as a GP. More filler. Okay, that's it. Thank you.
Next one.
Yep. So before I get on to health pathways, which was the poll question, just a brief introduction to the optimal cancer care pathways, and you can skip that slide. Yep. So the optimal cancer care pathways, a statewide initiative that's been set up, as Professor Sandhu was saying at the end of her presentation about continuing the education and engagement for GPs around cancer pathways. And the optimal cancer care pathways were developed to help describe the key stages in a patient's cancer journey, from diagnosis to survivorship or end-of-life care, and the expected optimal care at each stage to ensure that all people diagnosed with cancer get the best care regardless of where they live or how their cancer is being treated. The optimal cancer care pathways are accessible through the Cancer Council and through your local PHN and the use of the health pathways. And they're just trying to establish a best practice and consistent format for a patient's cancer journey. So, and they're aspirational. They are described to, they're there to describe what should happen in an ideal world for a patient, so not necessarily what's happening in the world. And I think that we probably as GPs all have experiences where patients have had cancer and come back to us later on and said that they felt lost at the time of diagnosis, or that they didn't feel they had all of the information or weren't sure where their journey was going to take them. So the optimal cancer care pathways are designed to help us as GPs and care providers, other care providers, to define and educate our patients in that time. They're also around providing some concrete action points for the patient as they go through the stages of their journey, and they can also be used to help us help us as clinicians to map where we might see opportunities for improvement in the care of those patients. So the optimal cancer care pathways come in 3 versions. Next slide. Yeah, thank you. So there's the what to expect guide for the patients. Then there's the quick reference guide for the GP, so the GP can familiarise themselves with the particular cancer that that patient's been diagnosed with and what they might expect from a GP point of view. And then there's the detailed pathway that the cancer specialists might use, or other health professionals, and as the GP, if you wanted to take on further information and have a more detailed knowledge about that disease. And these resources can be downloaded to your medical software, so your medical director or your best practice software, or they can also be accessed through the health pathways or the Cancer Council, as I said, and PDF printable versions can be used and given to your patients. So the next question is the poll question. So can you tell me the answers on that?
The 54% said yes and 46% said no.
About half. So there's a big group of people that are using health pathways and will be familiar with this. So apologies if I'm repeating information that you know, but the pathways are developed by the 6 PHNs throughout Victoria. So there's 3 in the city and 3 in regional Victoria, and they're localised to your particular area. So the pathways will have evidence-based information regarding conditions and symptoms, and they're drawn from the latest research, clinical guidelines, care pathway that have been agreed on by subject matter experts and best practice management, with links to relevant practice guidelines and publications. And so when I was reading through this presentation, I was wondering what are some of the barriers and what does best practice look like? And I feel like for me, one of the barriers in my practice is time and knowing where to look for a resource when there's a patient that walks through the door who has a condition that I don't have the information at my fingertips. And so using the pathways, you can have that open on your web browser, and it usually has a broad range of clinical conditions that you can refer to and take some best practice information, or it may be that you need a reminder about how to refer a patient, what is the relevant information that the specialist would want. Tonight, talking about melanoma, but any condition, and so there's a lot of detail that can be taken from the health pathways on a particular disease that would give you a quick reminder and mitigate some of that challenge that's there with time in the consultation if you have it open and you're ready to use it. And the second thing that it can provide is an opportunity for you to look at what referral options are available for you in a particular disease. So, and I find being in my town for some time, I have a number of people that are new to the town, registrars or new people that have come to work with me that knock on my door and say, who do you refer to for this, or who do you, where do you go for this particular disease? And in that regard, I think one, when there's new specialists that have come to the local area, the health pathways is up to date because your local PHN will know who the service providers are in the area. And then secondly, it allows you to refresh on who the people that are in your area that can provide that specialist service. So a case study, and I think there's been a number of case studies tonight, but I think from here we probably go to the live web page for Pathways so that we can demonstrate how you might use it. Yep, so a case of a 47-year-old woman who's had a lot of sun exposure, cumulative UV exposure over the years, presents with a mole that's changing and growing, and so some of those features that the previous presenters have talked about. And so now you can say, okay, what are the risk factors that might predispose to a melanoma? And you know, for many of you that might be easy, but for some of you that might not be as easy. So you can come here and say, okay, this lady's had past high sun exposure, she's got a changing mole. Some of the information there that's been spoken about previously, so high number of benign moles or atypical nevi. And then if you want to remind myself what's an atypical nevi, and you can click on the link on the drop down box there. Is that going to work? Sorry. And add that information to your referral or to your clinical assessment. It's not working. Okay.
Yep.
Are you on the slides or are you on the live website?
You want me to? Yeah, it's dropping now. Yeah, to go nearby.
Oh, you're right. Okay, so it's come up. Great. So you'd use the health pathways. You can use the health pathways there as an assessment, and then you're going down on it. So if you just go back up the screen there, you can see that the next headline subject down from that would be your management of the nevi. And as was discussed before, a shave or a partial biopsy of a suspected melanoma is usually suboptimal. So you decide to do an excisional biopsy on this particular mole, and you might think, okay, now I'm going to do an excisional biopsy. What do I need to do for an excisional biopsy? I don't remember. I'll go to clearance margins, and I want to know for a suspected melanoma excisional biopsy, what should my clearance margin be? And so you can see then that'll bring up all types of different skin lesions, but tonight I'm talking about melanomas, so we want to have a clearance margin of 2 millimeters for the suspected melanoma, and then that gives you an opportunity to get your diagnosis without breaking any of the rules that the specialists would want. And then we'll go down to the next section, which would be your referrals. And you might say, okay, maybe this patient's melanoma's on the face. It's difficult, and we don't think we can do a primary closure for an excisional biopsy. So we'll go to our referral section. So let me simply lost it again. And there you can click on a proficient peer that you might look for, or you might say, who are the referral options in my area? And obviously we've got Peter Mac and the Alfred. You may have a local plastic surgeon that was proficient in that area, or a procedural dermatologist who works in the area that can assist you with the next phase of management of that particular lesion. So yeah, okay, so we're back to the slides. Okay.
Oh, these are the slides.
Right. And then after you've done your referral, your patient may come to you and say, what happens next? What's my journey? And you've already seen the optimal cancer care pathway, so you've used that, but you want to download just go back one. You want to download so at the bottom of your health pathways page there, you've got your information, and there's information for your health professionals and your information for your patients. So you'll go from there to the Cancer Council website, what to expect for a melanoma, or you can head to other information for your patients. The optimal cancer care pathways are there as a link. So there's a lot of information within the pathways, and it's not so much just about what the clinical details are, but it's also your referrals and your information, what you might put in a referral, what the time frame should be for a referral for a particular disease, and then patient-related information. So that's it. Thank you.
Thank you, Dr. Fanning. And now we have 5 more minutes for questions. You can type in your questions in the question box. Okay, some of the questions we've got is, one of the questions is, on an average, how many biopsies is it being done for each melanoma diagnosis?
Yeah, so I mean, it depends who's doing the biopsying essentially, but and it will fluctuate. If you go through a patch and you get a melanoma that was perhaps you didn't expect, then your biopsy rate might increase for a period of time before you become a bit more comfortable with things. But typically in dermatology clinics, a ratio of about 4 benign to 1 malignant lesion would be biopsied, but that will vary significantly.
Okay.
If your biopsy rate's getting up to 20 to 1, you probably might think about referring a little more, but it is going to fluctuate a bit.
Thank you. And one of the other questions is, do you recommend any specific dermoscope?
So there are several different dermoscopes on the market, and they will have different abilities to connect to imaging cameras and so on. And so it's a matter of finding one that you feel comfortable and holding it is comfortable for you, and also fits in with what imaging you have in your practice. But I use a DL4 Dermlight, which I find really good. You can click between polarized and non-polarized, and use contact and non-contact. So having that versatility is good, but it's a good idea to go to one of the stands. If you go to one of the conferences, they usually have a stand, and you can have a little play with them and see which suits you best.
So continuous exposure of any other source of heat, for example, hot water bottles throughout winter, does it increase the chances of melanoma? Continuous, so say for example, solar exposure is one of the, any other forms of heat.
No, so you should be thinking about UV, not heat. So heat is not a risk factor for melanoma, it is the UV level. So the ultraviolet radiation that causes direct DNA damage, it's not to do with the heat.
What's the pathway for urgent referral for melanomas?
Both our clinics at the Alfred, and I'm sure it's the same at Peter Mac, will have a clinic coordinator that coordinates the melanoma service and triages the referrals, and we're usually able to get urgent referrals in within a week or two. So, do
you accept patients from other catchment areas as well?
We do, yeah, and that's the same for both centres. Yeah.
Yeah. And do you suture punch biopsies?
Yes, so most punch biopsies will require a suture. 2mm punch biopsies may not. It depends whether or not you've been close to a vessel or not. Some on the face, particularly around the nose or ears, might just bleed, and you might prefer to put in a stitch, but otherwise you can get away with a bit of pressure, and often use Caltastat or some dry claw on a cotton bud will help with hemostasis. So they're little tricks that you can use. And if you're just biopsying a rash with a 3mm punch on the trunk, oftentimes that won't need a stitch either. But on the leg, if you're going to send them off without a stitch, even a 3mm punch biopsy can bleed, and so it's a good idea to put a stitch in.
Okay. Is there any indicators prior to the start of immunotherapy to know if the patient is going to be a responder or a non-responder?
Unfortunately not. So they've done a lot of different ways. People have looked at mutational loads. They've looked at PD-L1 staining of the tumor to try and figure this out. In melanoma, PD-L1 staining is not particularly helpful, and you can imagine that if you've just biopsied one spot, it doesn't give you the whole picture of what all the different tumor sites are going to behave. So unfortunately not. We don't really have good predictors of response at the moment. The best predictor is actually the first 12 weeks and getting a good sense of what happens within the first 12 weeks and supporting them through that.
So we come to a final question for the night. The question is on the billing of suspected malignant melanoma. Do you wait for the results to come through before you bill a malignant melanoma?
Yes, you need to wait for the pathology before you can bill the melanoma item code. So for the diagnostic biopsy, you would bill for that biopsy code, and then when you do the wider excision, you bill for the melanoma.
All right. Thank you. On behalf of RSCGP and Eastern Region, I thank all the three presenters today, and I also thank all those who joined us for tonight. And on behalf of everybody, I would like to wish you a very good night. Thank you.